So like I introduced myself already, I'm Monica Thomas, the LVAD coordinator here at WVU Medicine, and this is a two-part series on LVADs, or left ventricular assist device. So we'll go through the first part this week, and then the first part of May will be the second part of the series. Next slide. So first, I just wanted to give a little background, a little talk about some challenges that we face in advanced heart failure. Next slide. So implications of heart failure in the U.S. So about 5.7, there's about 5.7 million adults in the U.S. that have heart failure, up to 1.5 million that are in advanced stages. So you have at least 25,000 patients that are appropriate candidates for advanced therapies. And there's an estimated amount of 3,200 donor hearts available for transplant each year. So that leaves, a lot of patients that need therapies, but don't have the ability for a donor heart. So about 270,000 patients die each year in the U.S. From heart failure. So about half of the people with heart failure die within 5 years of diagnosis. Next. Heart failure is the leading cause of death after cancer. It kind of sits up there with some of your aggressive malignancies. So when patients are in stage, class 4 heart failure on optimal medical management, their 1-year mortality rate is 75%. So you see right there with lung cancer and pancreatic cancer. Next slide. So heart transplant is the gold standard, but there is a limited supply of donor hearts available. So at least, you have 3,200 transplants per year estimated, and that's about 25,000 appropriate candidates for advanced therapies. So you can see there's a big difference in patients that need advanced therapies and the availability of heart transplants. Next. And this is the prevalence that shows heart failure as it continues to grow, and that the number of transplants has not been able to keep pace per year. Next. So that's where, LVADs come in, a left ventricular assist device. We use these in patients that have a weakened heart in advanced stages of heart failure. This is your class 3, class 4 heart failure patients. It does not replace the native heart. As you see in the image there, the native heart remains intact. It is a durable implantable mechanical device, and it does pump blood from the left ventricle to the rest of the body. So as you can see on the mannequin, the pump is actually sewed into the left ventricle. So it does require open heart surgery. They do core out a piece of the left ventricle and sew the inflow cannula of the pump into the left ventricle, and then they bring around the outflow graft, which ties into the ascending aorta. Then they bring a line that comes down and exits one side of the abdomen or the other. This is kind of the patient's drive line, or lifeline as I call it, because it's what's connected to the controller and the external components to keep the pump running. So it does have an internal piece for the pump is implanted internally, and it does have some external components to it, a controller and batteries for daytime use that do add a little bit of extra weight and nuisance to the patient at times. Next slide. So indications for use where we see LVADs being used, you could see them in emergent cardiogenic shock. The larger centers will do that. You do have temporary support devices that you can use when you do have patients in emergent cardiogenic shock that we often see here at WVU Medicine with the advancements in ECMO and Impella devices and balloon pumps. We always use these acronyms to describe these patients when they get an LVAD. Are they a BTT or a DT LVAD, and what does that really mean? BTT is bridge to transplant. So these patients are they are a candidate for a cardiac transplant. They're actively on a transplant list, but they're not going to be able to wait for a available donor heart. So in the meantime, we may implant an LVAD to kind of buy them some time to get them to heart transplant. So they'll be, labeled as a BTT VAD. And then your DT, or destination therapy VADs, are your patients that are not a candidate for heart transplant. For whatever reason, they're not a candidate. They could be a smoker, that kind of puts you off the list. BMI, greater than, 35 in some centers, 40 in others. can take them off the list. Other comorbidities, other end-stage organ and damage, age greater than 70, which is relative. And, destination therapy LVADs is a form of palliative care. When somebody's getting a destination therapy LVAD, this is kind of, with no chance to get to heart transplant, this is kind of the last, step in the game. One thing to note that even though we implant somebody as a destination therapy VAD or, a bridge to transplant or VTT VAD, that can change. You can initially be implanted as a destination therapy VAD because you're a smoker, and then you become smoke-free, you go through the transplant evaluation, and then you could switch over to BTT. Just as you could be a BTT VAD going into it knowing that you do have a chance to get on a transplant list, and you could have some complication status post-VAD that kind of takes you off that list. So I always go in, talking to these patients when they decide to, get an LVAD. I've had patients say to me, I'll do this if it's only temporary. I want to get to heart transplant. And they kind of going to go in it with, I may have this forever, because even though the goal is to get you to transplant, this is a bridge to transplant, it may not always happen. There are other things that sometimes, step into play, a massive stroke or some other adverse events that happen to these patients that could take them off the list. But knowing that this label can be, switched back and forth, and the patients have to be willing to accept that. Next. So hemodynamics in the LVAD. So one thing to know that these pumps, they flow over the cardiac cycle. They are continual flow pumps. You have axial and centrifugal type pumps. These patients often do not have palpable pulses, just due to the continual flow nature of the pump. So it's really important that when I do the education, the community education with these communities and ERs and patients and families and nurses, that they understand that piece. You see an unresponsive patient, and your ALS, BLS tells you to check for a pulse, and these patients may not have a pulse, but ideally still perfusing. So that's something to remember. These pumps are very afterload sensitive. So in the initial one of the initial slides there, where I showed you how the outflow graph ties into the aorta, the pump is sitting there, it's pulling blood from the left ventricle, it's tying it into the ascending aorta. It's at a set speed to do that. So pull out of the left ventricle, put into the aorta. And it knows the pump at that set speed. Well, as a patient becomes hypertensive, or they have a high SVR, that pump is trying to push against that high afterload, or push against that hypertension. It has it has a difficult time doing it. So oftentimes what you'll see in these patients as they become hypertensive is you will see, it leads to these like possible retrograde flow. So you can have retrograde flow back into the pump. Retrograde flow is always bad because it can cause stagnant blood or clot. You'll see reduced LVAD flow. So you may not see it on the, you may see it on the LVAD where, your flows drop. You should see a drop in flow. The HeartMate 3 is a lot better at calculating the flow. There are no flow probes in this pump, so that's kind of an estimated value, but you should see a reduced flow, and you'll see a reduction in the patient's cardiac output. Oftentimes, as these patients are hypertensive, not only are they at an increased risk of a stroke at that given time, but it's also difficult for that pump to push past it, and they're not getting the true, the true cardiac output and a true flow of these devices. So you can see a lot of times what I see a lot with the HeartMate 3 is I see a lot of low flow alarms in these patients, because it does have some mechanisms built in to kind of alert you of this. But you do oftentimes see that. I see it a lot. I've seen it several times in patients, when they come out of the OR and they're post-op, they're immediate post-op and they're hypertensive for various reasons, they're getting a lot of reduction in flow, and there's a lot of, chatter of, what do we do? How do we fix this? And oftentimes, just getting their blood pressure down to a normal pressure just instantly fixes that. So it's a really big thing that we always try to control with these patients. On the other side of that is it's preload dependent. So your CVP. So here's the thing with this pump. It's a left ventricular assist device, so it is supporting the left ventricle. The right ventricle still has to do its thing. The right ventricle still has to be able to do its thing to get, blood to the lungs, to get it back to the left side of the heart. If the right ventricle cannot do that, if for whatever reason, maybe the right ventricle's, it's just a marginal right ventricle, it's a failing right ventricle, or the patient's, just hypovolemic. immediate post-ops have lost a lot of blood, they're hypovolemic. You know, a patient 6 months, a year into the community, you know, maybe cutting his grass on a hot summer day becomes hypovolemic. So a lot of times what you'll see in these patients that are hypovolemic or have a poor RV, the inability of that right ventricle or to be able to get volume over to the left side of the heart. So you'll see a reduced ventricular volume. Oftentimes you'll see suction conditions or a suction event happen with these patients because it's a set speed, it's a fixed speed that we set these pumps at. So the pump is pulling blood from the left ventricle, tying it into the ascending aorta. That's the cycle. If there's no volume or blood in the left ventricle for that pump to pull out of the left ventricle, what's going to happen? It's going to pull, and the ventricle is just going to collapse. It's going to suck down on itself, and you're going to lead into these suction conditions where it's pulling volume or blood that's not there. The ventricle continues to suck down on itself, and oftentimes if we allow this to happen over a short period of time, you'll start to see where the ventricle's collapsing and it's pulling the septum. So the septum that sits between the right and left ventricle, the septum's being shifted over to the left ventricle, and the right ventricle does not like that. And then you end up in a situation where you end up in either more right ventricular failure, or a patient that wasn't in right ventricular failure just due to a volume issue that maybe wasn't corrected or noted could end up in RV failure. In RV failure, you know, there's not a whole lot with a patient and an LVAD what we can do for RV failure. There's temporary support devices that we can utilize, or IV inotropic medications that we can utilize, but there is no FDA-approved durable implantable RVAD. So these patients can't go home with something implanted into the right ventricle. There are large centers that do put in RVADs and do, you know, biventricular assist device in these patients. The outcomes aren't the best, and you don't see it very often. So really, you know, you have to protect that right ventricle with their volume. So really important to manage their volume status and their blood pressure. These patients still have a failing heart in there, so we like to see them normotensive, and we like to see them euvolemic. That's really important, just like we would like to see any heart failure patient. So you're managing a failing heart on top of all this. The LVADs do have alarms in place to notify us of things, which is nice, and they're very user-friendly alarms, so patients can go home and live in the community. And when they have an alarm, they call me, and we kind of work through it with a bunch of questions and looking at a lot of different things. But they have these low-flow alarms to let us know. They do trigger suction events, so as we're able to interrogate their LVADs and look at things, we can get an idea if these patients are truly having suction events and sucking down on that ventricle. But one thing, and I'll say this probably multiple times throughout this presentation, the best way to determine if you're not sure, is the patient sucking, you know, are they having a suction event? You know, is there a volume status issue? Like, what's going on? Echo. An echo is your friend. A transthoracic echo, they're so easy to do now. Most doctors, if you see them, they keep echo probes in their pocket and hook them up to their smartphones. If you're ever in doubt of what's happening, throw an echo probe on their chest and just take a look and see if you can see the RV. Can you see the septum? Is the left ventricle unloading? What's truly happening? And that's it's not invasive at all. It's a pretty easy thing to do and pretty quick to do in a clinic setting or in a hospital setting. Next slide. So equipment and parameters. So the device, all the devices have a controller, and it has cable cords that are attaching to it. So the pump exits, the driveline exits one side of the abdomen or the other, and that driveline or lifeline hooks into the controller. That controller then has two cable cords, a white cord and a black cord, that attach to, for daytime use, two 14-volt lithium-ion batteries. And then at night, they have a power source, a mobile power unit. It's about this big. It's not very big at all. And it is plugged into the wall for wall power. When they're plugged in at night to the wall power, their batteries go onto a charger to charge. Batteries in these pumps last, that's always the question I get, that pulls simultaneously through the two batteries. The pump's batteries can last anywhere, you're looking at maybe 10 to 17 hours. The HeartMate 2 was higher in power consumption. The batteries didn't last quite as long with it. It was more on the 10-hour mark. HeartMate 3 has, you know, a little less power consumption, a lower speed. So those batteries tend to last the patients about 17 hours. Always for emergencies, I always make the patients have an extra bag. It kind of looks like a camera bag. And basically it has their extra equipment in it that they carry with them at all times. It is in, it's in a, it looks like a camera bag, and it's an extra controller and extra battery. And what it does is, in the event that something would happen and the patient's controller would malfunction, I teach the patients and their caregivers how to do a controller exchange if they would have to do that. Or we do go through it with our EMS in the area where these VADs, the communities that they live in, we teach EMS how to do that. Dr. P.S. Martin does a lot of my pre-hospital education, and we do a lot of outreach with the EMS in the event that they would have to. Because if their controller goes bad, malfunctions, quits working, their pump stops. And their backup batteries are in the event they get into a situation that, their batteries die or drain or malfunction, they have extra batteries so their pump doesn't stop. The controller itself does have a backup battery installed in it for like emergency use, and it can run about I'd say about 15 minutes or so is what the company says. There's been talk that they last a little bit longer than that. I tell my patients, this is emergency use only. You're plugged in at night, your power goes out, that backup battery keeps your pump running so you can get to your actual 14-volt batteries. It's not something I like to see the patients use. And when I interrogate their device, if they're running off that backup battery, it does alert me of that. There are parameters that we follow and trend with these patients. There is a set speed that that the clinicians will set. We'll set it in the clinic or in the hospital setting prior to discharge, and we figure out that set speed. A lot of time that speed is set under echo guidance. We will look at a transthoracic echo and just determine the appropriate speed for the patient, that we're truly unloading the ventricle, that it's unloading, but it's not causing suction events or other issues to the patient. With that set speed, it'll give us a power. How much power does it take and watts to run at that set speed? So if your set speed is 5,000 and it takes 3.5 watts of power to run at that set speed. So those are true numbers that are displayed. Flow's a little bit different. Flow is not, like I stated earlier, there are no flow probes in this pump. So flow is an estimated value. It's an algorithm determined by the company to kind of estimate the flow that the patient has. It can give up to 10 liters per minute per flow. The average, the patients usually, they can run anywhere from like 2.5 to 10 liters per minute. Anything less than estimated that's less than 2.5 liters a minute, you will trigger a low flow alarm. And that's kind of been built into the algorithm through the company to kind of, state that maybe there's not good blood washing of the pump to kind of prevent thrombus or blood from pooling or being stagnant. So that is, that's kind of where you're at with flow. But a lot of these parameters, PI, I'm not really going to go into PI because it's pulsatility index, and it's another algorithm, and it's really a very difficult one to understand. You don't see the PI in the HVAD, you only see them in the HeartMate products. But basically, the biggest thing I can say with these parameters and looking at these numbers, and anytime I give a presentation to any patient, any population I give a presentation to, you cannot look at one number and make a decision. You cannot look at the flow and determine what's happening. You cannot look at the PI. You cannot look at one number and just say, okay, this is what's happening. You have to look at the true clinical picture. You have to look at your parameters. You have to look at the patient's baseline parameters. You have to look at their trends and parameters. In addition, you look at your hemodynamics. Sometimes I think there's blinders on you, especially when you have a patient in ICU, that you have all these parameters to look at and all these hemodynamics, and you focus on one number, and it's like that, you have all these other numbers to look at. With that being said, I send patients home and they write their numbers down every day. They write their parameters. Every morning they get up, they go to the bathroom, they weigh themselves. They write their parameters down. They take their blood pressure. 2 hours later, they write down their daily weights. They write down their temperature. They write all these numbers down on a log for me. They come into clinic, and when we interrogate their device in clinic and we look at their log, we can see, is anything trending one way or the other? Are there, alarms on interrogation on a certain date and time that matches something on their home log that kind of triggers something for us? Were they having alarms and what was going on? So it gives us a good clinical picture when we're not seeing these patients every day, when they hit the outpatient setting, of what's really happening. So we really rely a lot on that to determine, what's happening with the patient. Another thing to note here, that at any given speed, if you have a patient has an increase in blood pressure, you will see a decrease in their flow. Next. Key points with equipment that I always tell anybody: if these patients show up in an ER, they show up in a clinic, wherever they show up, knowing that you may not see the equipment. You know, you saw the mannequin and you see all this excess equipment, and some patients do, they wear their equipment on the outside of their clothes. A lot of people wear it inside. You'll see a lot of different vests or clothing, compression shirts with pockets where the equipment's inside. Inside their shirts. So you're not really seeing that. So being mindful that if these patients show up, that we're not, you know, tugging on their equipment, pulling on their controllers, tugging at their drive line. You know, I always think about the patient that gets flown in, and, you know, you're grabbing a patient from, you know, a gurney to a bed, and you just, you know, grab the white sheet, put them over to the bed, and the drive line's white, you jerk on that. You know, you put a big risk of infection for these patients, because that skin around that drive line needs to seal. And as that, you know, if that doesn't seal or there's a break in that skin, you put the patients at a pretty big increased risk of a drive line infection. Really important that wherever these patients show up in the community or in the hospital, or you come in contact with them as a provider, or you know, with these patients, that they have their backup equipment. Do they have their little bag that has their backup battery and their backup controller? That's really important. If they show up here at WU Medicine, I have backup equipment in the event that they forget it, that I could utilize. It's like a loaner backup equipment, but that's not other centers that we have in West Virginia. So really important. I do a lot of education with the patients. You know, you have to have this backup equipment with you. And they forget it. They get tired of carrying it. So it's a lot of re-education with these patients. And making sure that, you know, that the backup equipment does travel with the patient everywhere they go. Another thing too, if these patients do show up in these clinics, if they do show up in one of our outpatient clinics, or, you know, another hospital setting that's, you know, not LVAD trained, or, you know, the biggest thing to note is the patients, if they're alert and with it, they are a huge resource. They've been living with this LVAD. They go through a very extensive education program. I spend hours and hours, you know, training the patient and the caregiver on how to manage this device. You know, at first they know nothing. They're overwhelmed. They're not medical. By the time they hit that 4-6 month mark, they are like the gurus. Like, they come in and they teach people how to take care of it. They teach them how to do their blood pressures, because they're different. They teach them what the device is and what it means. I actually send them after they start to heal a little bit and start feeling good after surgery and they're back in the community. I make them go to their local EMS, their local volunteer fire department, and introduce themselves and show off their equipment, so that those EMS providers and first responders and their PCPs, you know what this equipment is and get to see it. There's not a lot of LVADs in the US. A lot of people have never seen one. So with the patients going in and showing their stuff off, you know, it helps those guys to see it, you know, depending on the area you're in. Next slide. So complications of LVADs, where are these patients, like, when are they coming back to the hospital? Why are they coming back? Why are you seeing them in your ER or in your primary care clinic or wherever we're seeing them? This is what happens: bleeding. These patients bleed. They have GI bleeding, they have strokes, they have nosebleeds. And here's why. There's several reasons why. One, they're on blood thinners. They're on aspirin, they're on warfarin, and then sometimes we also put them on another antiplatelet therapy. You'll see them on Persantine or Brilinta or Plavix. So some of these patients can be on triple therapy. So that's number one, they bleed. Number two, it's a continual flow device. The heart goes lub dub lub dub. Continual flow devices just causes AV malformations in a lot of the vessels of the vasculature. So you do see bleeding due to AV malformations. And then another piece of it is acquired von Willebrand factor. So you're kind of getting a lot of things hitting them that causes this bleeding. So we do see a lot of bleeding. Sometimes it's minor, easy bleeding, a little bit of a nosebleed, cautery, with the local ER. And I've seen nosebleeds so bad that we're in an OR going in and scoping and trying to figure out the source of the bleed. So it can be, life-threatening bleeds, or it can be minor bleeds, but we always educate and monitor these patients on signs and symptoms of bleeding and who to call and what to do. Infections is another big one. You see in these patients drive line infection. So the drive line exits the abdomen. You get a break in that skin. You pose the patient a big break with the drive can turn to a bloodstream infection. Anything really could cause these to have bloodstream infection. So it's really important that, they monitor for signs of infection, monitor their temperature, they get educated on signs and symptoms of infection. They get pocket infection. A pocket infection might happen. So we're really try to stay on top of infection.
Hey everybody, I think Monica may have just dropped off for a second. Let's try and get her back on. We'll halt for 1 second.
All right, am I back, Caitlin? I think, sorry, it just went away.
It's okay, the internet is weird. We waited for you, yeah.
Sorry. So oftentimes these patients do have, device thrombus within their pump, or they end up with thromboemboli. So we do monitor for signs and symptoms of clots. We do monitor for and teach patients signs and symptoms of stroke. I do a lot of stroke education with these patients. And then this is what you see. This data is a little bit old. It doesn't really include the newest pump, the HeartMate 3. This came from the University of Colorado, and it's kind of more from the HeartMate 2 and HVAD data. But basically, potential complications 1 year after surgery. So you have 5 to 6 patients out of 10 readmitted to the hospital for whatever reason. You have 10% that have a disabling stroke. About 20% end up with a device-related infection. About 20% have a serious bleed that does require medical attention. And about 5% have to have surgery again to have their pump replaced. So you look at those numbers and you're kind of like, ugh, like that doesn't sound like something I really want to do. I don't want to deal with that. But when I walk in to see these patients, when they ask me to do an LVAD evaluation on a patient, these patients' prognosis when I walk in that room is like 6 to 18 months to live. And, when you're faced with that, it depends on, it does depend on where you're at in your life, but, you have to make that decision. I take these potential complications and these numbers, or, do I not? And it's ultimately the patient's decision. And I always tell them that I'm here to provide you with the resources and the tools to help make a decision. But, if you are a candidate for an LVAD, it's ultimately your decision if you want one. But the goal of putting an LVAD in a patient, and the true reason, I say this all the time when I do this presentation, and I truly mean it, the reason I do my job is because when you put an LVAD in a patient, they live longer. They are out of the hospital. They're not this frequent flyer heart failure patient that spends all this time in the hospital. So they're not in the hospital all the time, and they have an improved quality of life. Most of these patients can't do things. They can't walk down the hall. They can't play with their kids. They can't play with their grandkids. And, when you give them that opportunity to do that, that's truly the most rewarding thing. Next slide. Blood pressure management, huge in LVAD patients. So these patients really need their blood pressure managed. So it's difficult to get a typical blood pressure on these patients like you would you or I, because it is a continual flow device. So you don't get a systolic diastolic pressure. These blood pressures are taken with a Doppler and a manual cuff. It's really easy to do. I teach the patients usually in about 5 minutes, and their caregivers in about 5 minutes how to do the pressure. So basically it is a little bit of ultrasound jelly, the manual cuff on their arm, Doppler in the brachial area or even the radial or ulnar area, and you will hear like a swoosh sound. You inflate the cuff until that goes away. I usually tell people go to at least 100, 120 millimeters of mercury. As you slowly release that cuff, you'll hear that return to flow or that whoosh come back, and that's their pressure. And you'll chart it as one number, 80. And that should correlate, if the patient had a true invasive art line, that Doppler pressure should correlate to a mean arterial pressure. So when you think about a Doppler of 80, you're like, 80? What is that? That's terrible. Is that good? What is that? And you think, well, let me correlate that to a mean arterial pressure. And a mean arterial pressure of 80 is pretty good. So I always say, think about this, 70 to 85, I'm a happy camper. If you can keep me 70 to 85, or the patient 70 to 85. When they start to get above 85 and definitely above 90, you're going to start seeing that, that's that increased afterload, that hypertension. You're going to see reduced flow on the LVAD. You're not going to get their good cardiac output. And when you see these patients less than 70, some of the times we'll say, oh, 65 is good. They're hypotensive. Like, they have signs and symptoms of hypotension. They're lightheaded. They're dizzy. You see these things. So if they're consistently below 70, even below 60, you want to start doing like your differential. Why are they so hypotensive? What's the problem? So you really want to keep them. That goal is that. And I like that little tight window, that 70 to 85. It'll trend one way or the other. And we may say, how's the patient feeling? How do things look? And they may run a little higher, potentially a little lower. You may see these smaller people that just run a little lower, and that might be okay. So really it's, what's normal for the patient. So when they show up in these clinics or show up in these ER, what's your normal pressure run? I run 72. They'll tell you, they'll give you an exact number, and that's usually where they live, and that's where they feel the best, and they'll tell you that. Next slide. I think, sorry, I'm just gonna look at my notes to see where I'm at, because I'm gonna stop here in a minute and finish next time. So target pressure goal, that says 70 to 80, 70 to 85, not to exceed 85. A lot of times once they consistently start to hang above 85, the 90s, we'll start adding meds to bring them down. Sometimes, they come in an acute, hypertensive phase, looking at some hydralazine. That can always be your best friend. When we're dealing with them in the outpatient setting and they get hypertensive, we just start adding some meds back to them. One nice thing with these patients is, they can't tolerate a lot of these heart failure meds pre-VAD because they're hypotensive. And then post-VAD, they start, to get some flow again and get a little hypertensive, so we can start putting some of these heart failure meds back on them. And you'll see that a lot on these patients. You'll see them on Entresto and beta blockers and things like that. And it's kind of good because it helps a little bit with potential recovery of the ventricle too. So they are on a lot of heart failure meds as well. Hypertension can decrease forward flow, so you will see a decrease in the pump flow and the power. Really important to manage that hypertension because it does optimize cardiac support, and you reduce the risk of a stroke. Big thing to remember when these patients do present, or you do see them in certain settings, or, you're seeing a guy in whatever clinic it is. I mean, these patients, they have cataracts, they have to have, colonoscopies, they, have to have skin cancer removed. They have all these things that are done to them at either a same-day surgery or an outpatient clinic. Remember that they're on anticoagulation, and it's really important that, nobody messes with that anticoagulation. We have our VAD team with trained pharmacists that they manage this anticoagulation in our program. So if these patients do have to have a procedure that requires them to go off their, Coumadin or warfarin for whatever reason, we do bridging with them. So it does require, a combination of people and a lot of coordination to have that done. So a simple procedure that you or I would go in for becomes a big deal to a VAD patient because you are starting to mess with their anticoagulation and bridging them. So be mindful of that. Really important that we don't reverse these patients. They come in with an elevated INR, you don't want to reverse, oh my gosh, their INR is 5, 6, whatever number you want to give it. And you're any other patient, we should reverse them, they're at a risk for this. We really try not to reverse these patients. I'm not saying we don't ever do it, because there are times, risk benefit that they do get reversed or have to be reversed for, a life-threatening bleed. But if we don't have to reverse them, we won't. We'll just kind of watch INR trends. Will they be hospitalized and monitored very closely? Absolutely. But knowing that it's just, your first guess isn't, let's just reverse them. You really want to talk to the VAD team. We have VAD attendings on call. There's always a way to get a hold of one of us to kind of make a decision on what to do. These patients come in bleeding or with really high INRs. Big thing is blood products. We're really kind of watch giving these patients blood products. We don't like to introduce different antibodies into their system. These guys, especially if they're transplant potential. If these patients have a potential to go to transplant, no blood. Sometimes you have to, it happens, but you're really kind of I really don't want to give this guy blood. I really, really don't want to do that. And then if, they're never making it to transplant, I had a guy that I knew was never making it to transplant. He had pretty significant lung disease. He felt good at a hemoglobin of 9. His would drift down, and we'd give him blood just really to kind of beef him up and make him feel better. I'd never do that with a BTT VAD, but with him knowing that he was never getting a transplant. But it's a big thing. Whenever these patients show up in your clinics, in your hospitals, in your ERs, just call us, call the LVAD team. You'll get our contact information. We're really easy to get a hold of. this is my life. So these are 3 phones. I'm really not hard to get a hold of. My docs are like at a fingertip away if we need anything. You can always call the Mars line and get in contact with me or the VAD attending on call. And we can kind of help guide getting these patients wherever, if they need to be transferred to us or wherever they need to go, or help you to manage them in the outpatient setting. Where are we at? Well, you know what? Let's go one more slide, Caitlin, and then we'll just stop till next time. So just real quick on arrhythmia management. So really important with these patients, medical treatment, with the exception of chest compressions, we follow BLS and ACLS protocol. You can give them amiodarone, you can give them lidocaine, you can give them xylitine, you can cardiovert them, you can defibrillate them. One thing that I will remind anybody of that comes in contact with these patients, you know, you have a patient, you hook up to a monitor, you see what you see on the monitor, you're going to get a EKG read. The pump's really not going to interfere with that. You might get some artifact on the, some artifact on an EKG, but you will see, a typical EKG. And these patients can be in life-threatening arrhythmias, VFib, VT, and talking to you. They have a continual flow device. They're getting forward flow. They're perfusing, even though the heart's in there and it's quivering in VFib. The patient's wide awake and talking to you. And I will tell you, it is the creepiest thing to see. They're talking to you and you're looking at the monitor and you're like, should I fix my leads? Like, what's happening? And then boom, their ICD hits and you're like, nope, that was right. And they're awake and they're feeling this. So one thing to be mindful of, I watched a guy get shocked 7 times in VFib. And then we had to cardiovert him externally to shock him out because his device couldn't get him out of fib. He failed all 7. We were in the ICU, so we were able to sedate him before we externally defibrillated him. So that was kind of nice. But be mindful of that. They're awake and they're feeling this. It's not like your typical patient that goes down and doesn't feel this. But we do not like them in those rhythms, even though they're talking to you and they're, you're like, oh, they're perfusing. Over time, and not a long period of time, a short period of time, the ventricle's in there quivering. Blood's going to get stagnant, blood's going to clot, you're going to clot your pump, you're going to cause a stroke. So really important that we don't let these patients sit in these rhythms for extended period of time, that we do, get them out of these arrhythmias. Big thing with CPR, really important here, is the pump running? So a patient comes in, the patient's unresponsive, is their pump running? You look at their controller, you see the green arrows, green circle of life, the pump's not alarming, the pump's running. You listen to the patients have this bad hum. It's a mechanical hum sound of the pump. There's no lub dub like a typical person that you auscultate on. So the pump's running, the patient's unresponsive. So don't do CPR, hands off, do everything else, no CPR. That pump's running at 5,000 RPMs, 10,000 RPMs, depending on the pump you're dealing with. It's perfusing the patient. So you can give meds, I know everybody's like, no CPR, how do the meds get through the body? That does. The pump's doing that for you. Another thing to think about, if the pump's running and the patient's unresponsive, think outside the box. When you're going through your H's and T's in a code situation, when you see a patient unresponsive and that pump is truly running, it's something else. It's not the heart if the pump's running. It's really not. They're hypoxic. They have a mucus plug. They're acidotic. It's something else. So it's a stroke, like take your mind out of, the pump, if that pump's running. Now you run into a situation, pump's not running, patient's unresponsive, nothing. Last resort, we would do chest compressions on those patients. But it's, the company they won't speak to it. Their thing is, it's your program's decision whether you do CPR or not on these patients. And you can go to program, and everybody does something a little different. But our thing is, if the pump's running, hands off. The fear is that you could dislodge the pump, you could dislodge the outflow graft in the ascending aorta, or dislodge the inflow graft into the left ventricle and cause more problems. But in the event of a true emergency, you get these patients, call us. We'll kind of walk you through stuff or help you out or do whatever we need to do. Caitlin, we can stop there and take questions, or if that's okay.
Absolutely perfect. Thank you. That was wonderful.
Thanks.
Yeah. Everybody, do you guys have any questions? You're welcome to chat them in if you can't unmute yourself.
I had a quick question. That was excellent. Thank you. Mine is probably a pretty simple question, but I was just wondering how LVADs affect patients in their personal life. So, something as simple as how they can shower with it or exercise or travel.
That's a great question. Because, one of the things I said is, well, we improve your quality of life, but it comes with some baggage, right? You have all this external equipment that you have to man and take care of. It's about 5 to 7 pounds. And in terms of showering, it becomes a little more difficult. We do not let them submerge in water. So no bathtubs, no hot tubs, no pools. But once things heal, the driveline exit site sealed, their sternotomy is healed, we do allow them to shower. We have a shower bag that their equipment goes in that's waterproof, so they can put their batteries and their controller in that. And then we have them cover their dressing of their driveline exit site. A couple patients will use like a saran wrap to wrap around it, and some just use a larger clear dressing to place over it while they shower. And then immediately after a shower, I make them do a dressing change, because I don't want any water sitting around that driveline exit site to cause infection. In terms of exercising, one of the things I always ask the patients is, when I meet somebody for the first time, what is it? What's your hobby? What do you love to do? What's the thing that you can't do now that's because of your heart failure? And, the goal for me and your goal is to get you back to that thing. So if people are big into exercising, there's workarounds. There's different ways to wear the equipment. I get them in contact a lot of times with, I have, support groups, myLVAD.com, Facebook support groups. We do a support group to get these patients together to talk about, tricks of doing things, of how do you exercise, how do you do these things. We advise against contact sports just because of the driveline and the extra equipment and dislodgement and stuff. However, if their passion is, something along those lines, we try to figure out a way to get them back to doing those things. I have a guy that I just implanted. He wants to start working out again. He loves to jump rope. And I'm like, ooh, we had a patient with a pogo stick and their outflow graft twisted, and jump rope makes me a little bit nervous, but we're going to work through it and get him to the point. He said, it's not big impact. Like, I'm not really I'm like, it's light. So we're going to work on that to get him to, once he heals up, to do that. But it's a lot of just working with the patients and working with the community to figure out what works best for people, and reaching out to other centers and other patients to kind of get feedback on what works for them.
Thank you so much.
Any other questions, anybody? We have about 10 minutes left. Monica, I was going to ask, you're welcome to ignore this if you're going to discuss it next time, but what kind of the reference process is from PCP to getting a VAD?
So typically we have them, if they need a patient that needs a VAD workup, so they're coming from the outpatient setting, we have them put a referral in. So they'll send a referral in to Deborah Harrison, takes all the referrals and reviews that stuff with Dr. Kakamo to get these patients set up in the outpatient world. And then we start the referral process. And I am in the next series sending some information on what constitutes a referral. Like, how do we know that a patient's truly a referral for advanced therapies? And, what criteria should they meet before they get referred over? And I'll have a slide on that for next time. But really, if you think a patient needs an LVAD or needs an advanced therapy workup, call us, call me, and I'll get these people through, get the information over to Deborah. We like them to have an echo. There's some testing we like done that they send over to Deborah to review. And then when they do see the doc in clinic, we make sure all this testing's been done so that we can evaluate them in a timely fashion. Oftentimes, these patients don't come through the clinic setting. Oftentimes, it's an in-hospital transfer. The patient shows up to an outlying hospital and they're in cardiogenic shock, like they're bad shape. So they call us and transfer them over, and we're doing inpatient workups, which, it's fine too. We'd love to have them in the outpatient setting because they're, they do better the kind of healthier they are. And we'll go into that a lot more next time. They have better outcomes, but ultimately sometimes these patients slip. Like, that's the thing with heart failure. You're doing good. You have an exacerbation, and that might be the one that kind of puts you over the edge. So we try the best we can to get those patients in that extremis and do these workups to get them to, an LVAD or to the workup, to whatever advanced therapy they need. Sometimes it's too late. That we kind of did get them too late, and that often happens. But, I say send them, or, talk to us and we can evaluate. And we always do. My docs are awesome. I love these guys. They're really good about feedback. So if a provider sends somebody over and maybe they're not a candidate, we do feedback, this patient's not a candidate because of dot, dot, dot. And they're like, oh, okay. So then they know next time I'm not going to send this type of patient because they're not a candidate. So that's, I think, helpful to know, because a lot of outlying people don't, you don't deal with this all the time. But we're here to be a resource and help and guide that.
That's perfect. Thank you. So guys, Monica is going to be presenting for us again at the next session. That's going to be on May 1st. So if you guys do have any questions, you are welcome to email me or Mitra those, but you can also bring them for the next time and we can definitely get them addressed. And if anybody you think would be interested in this presentation, we'll post it to YouTube, of course, so they can watch it and then come to the second part without having missed anything, okay? But everybody have a wonderful day and we'll see you later. And thank you, Monica. Perfect.
Thank you. Have a great day.
Thank
Thanks.
you.